This podcast is sponsored by PAX. Whether on water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Renowned for their durability, they endure harsh conditions while providing rapid and reliable access to essential kit. So their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. PAX bags are designed with infection control in mind and are easy to clean and disinfect. Their highly visible colours and reflective strips add quick identification and adherence to quality standards, assuring reliability. The versatility of PAX bags caters to a diverse EMS providers, but also delivers vital equipment and durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations and they're absolutely excellent. Please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're going to dive into the critical topic in the domain of medical legal practice around documentation and communication for pre-hospital clinicians. So this is going to be the first in a three-part series on medical legal practice. And in this episode, we're going to focus really on documentation and communication. It's true to say that accurate documentation and effective communication are more than just administrative tasks. They're the key to ensuring patient safety, defending clinical decisions, and indeed protecting providers from legal challenges. So every action and decision made in the field must be carefully recorded, as inadequate documentation can really expose staff to a significant legal risk and impact patient care. So to do this, we're going to really explore the best practices for pre-hospital record keeping, legal implications of incomplete and indeed inaccurate documentation, and how clear communication during handovers to hospital teams can make or break a case. So we're going to examine some real-world case studies, but also highlight situations where discrepancies in documentation or indeed poor communication led to legal issues or adverse outcomes. So to do so, I have Mark Faulkner with us. Mark is an Associate Clinical Director and indeed Consultant Paramedic for the London Ambulance Service. He's also no stranger to the podcast. Welcome, Mark, to the podcast.
Hi, Owen. Thanks very much for having me back.
It's great to have you with us. Mark, you were really front of mind actually when I wanted to have these conversations, because you indeed have worked in the legal domain for so many years actually, and seen a really wide variety and disparity of documentation. Could I just initially get you to speak to why it's so prudent and important to have accurate and thorough documentation for pre-hospital providers to really ensure medical legal protection?
So I think, Owen, I would often describe the purposes of a clinical record as threefold. And I think it's always really helpful to think of records of having three purposes. One of which is around a continuum of care. It's a continuity of care. It allows those looking after a patient in a hospital setting to understand what happened pre-hospitally, understand the treatments delivered, what you found, what your assessment found, and inform and about what has happened pre-hospitally. And it provides that continuity of care. The next kind of purpose is very much the internal process of audit and review and assurance of our care. How are we looking back at the care we delivered to our patients to say, are we providing the best quality care? Is that care according to our SOPs, our guidance? And allow us to review and undertake that. And then the final purpose is as a medical legal record. It is the record of your care. It is effectively what Lord Justice Wolfe said in Access to Justice. If it isn't written down, it didn't happen, as an old boss once said to me. And that is really, really key, that they've got those three purposes. There is a kind of sub-purpose where you can have kind of three purposes. The fourth is a little bit of a research tool and around the ability to capture information for future research. But I think that we define records as those kind of three main key clinical purposes.
Absolutely, Mark. And to your point about those three domains, it's prudent to, I guess, in a way, be as accurate and as explicit as you can for all those three purposes. But could I get you to speak to the medical legal domain for actually when there is potential legal consequences of inaccurate or incomplete documentation. I think me and you have both probably been on the end of really trying to dig into the details, and there've been a real dearth or sparsity of detail, and it can cause significant issues. Could I get you to speak to that?
Yeah. So my kind of background is I'm a advanced paramedic practitioner, critical care in London, and have been since the inception of the scheme. But for the last 10 years plus in London, I have kind of headed up our clinical legal team, and now have some great people who work for me doing much of the day-to-day hard work, and I just get wheeled out for the really sticky stuff. Um, but I spent a lot of time gripping the bar in court, and more recently as an expert witness. And I'm probably one of the relatively few pre-hospital expert witnesses who's actually spent quite a lot of time in court. Lots of people do pre-hospital expert witness work, write reports. Um, I've one of the few, I think, who spends any kind of time, and I get instructed in some cause of death work and bits like that. And as you say, when you look at a case that comes under scrutiny, and none of us ever want to be in that position, but when your case comes to scrutiny, it's your records that are being examined, because that is the contemporaneous or the near contemporaneous account of what went on. And it's the records that you go back to. And it's the records that people look at. And really, it is the only defence that you have. We're having lots of conversations in pre-hospital care about should we be video recording, and there are some very eminent pre-hospital physicians that are saying perhaps we should all be wearing body cameras and that becomes our record. But we're not there yet. I have some views and around kind of video recording in pre-hospital care, and I think it's got a place and I think it's got a use. But whether it passes the Mark's mum test at 3 o'clock in the morning is a completely different matter. And when my mum falls over and damages a hip yet again, and somebody turns up to help her in her and she's in her 90, does she really want somebody filming her with a body worn camera? And I'm not sure the answer to that is yes. So I think video recording has a role, but I'm not sure either as a society we're there yet. So that comes back to that our record of what we've done, our only defence is our clinical records. And I guess it's probably reasonably helpful. We're both paramedics, so we kind of look to the HCPC as our regulator. And the HCPC now has three standards around our record keeping. And 10.1 is you must keep full, clear, and accurate records for everyone you care for, treat, or provide services to. And it goes on that at 10.2, you must complete all your records promptly and as soon as possible after providing care, treatment, or other services. And then 10.3, you must keep records secure by protecting them from loss, damage, or inappropriate access. And those are fundamental tenets that we're asked to sign up to as paramedics every 2 years. We're saying we're being compliant with those. They're not dissimilar to the standards within the GMC, the NMC, and other regulatory bodies. And actually, they're not dissimilar to the standards used internationally for colleagues. That fundamentally, we are obliged to keep records, and we're obliged to keep clear, full, and accurate records. And I really like the kind of concept that you should be able to reconstruct the consultation or the call or the event from the record. You should be able to read a record and have a reasonably good understanding of what occurred.
I know, absolutely. I agree with all those points, Mark. And I think, and I'd like to get you to speak to this. I'm just going to sort of, what I guess my record keeping changed significantly as a senior clinician when I was doing the advanced paramedic practitioner role to really look at not necessarily the negative the negative aspects of what the patient doesn't have, but certainly document what the patient did have. Now, I'm not saying it's not prudent to document the absence of chest pain or the absence of something else, but actually, rather than just document a full page of negatives, which doesn't give the a senior clinician or indeed an auditor really a fundamental idea of what was wrong with the patient, what was the major complaint, what were some of the tenets of that complaint. Could I get you to speak to, I guess, in a way, some of the essential elements that should be recorded on a pre-hospital care report to make it legally sound?
So I think you're absolutely right. Pages of pertinent negatives don't add anything, and actually, rarely do pages of clinical records actually add anything at all. And there is something around concise record keeping in it. It's a skill that I don't think we are particularly good at teaching colleagues coming into our profession and coming into our workplace about how you keep that concise record. And it is that record that allows you to recreate the clinical encounter from what occurred. So what you found when you walked in, what did the patient tell you what's going on? What did others tell you? What did you find on your investigation? And then from there, yes, the pertinent negatives, and they are pertinent negatives. And then what was your plan? And then if you had a plan and you didn't comply with the plan, why you didn't comply with it, or what were your exceptions to the care, why things didn't happen. And it is that kind of reporting by exception. I wanted to immobilize this patient or movement minimize them, but that wasn't possible due to agitation. I attempted to counsel the patient around movement minimization, but the patient continued to move despite counseling. We discussed with the patient the clear risks of this. Those included potential for worsening of neurological symptoms, plus or minus paralysis. But you can do that in a concise way. There is nothing that makes you focus on your own record keeping more than when you're gripping the bar in a courtroom, be that an inquest, be that a civil claim, be that a public inquiry, and you're being cross-examined by an eminent KC barrister who's decided to pick a hole in your record keeping. And that, I think, is one of the things it was an absolute moment for me of stood there going, right, I need to get better at this because this is how I defend myself and this is how my care is going to be. And many years ago, I gave evidence, and I'm sure Dr. Natman will not mind me naming a very eminent, now retired coroner of Inner London West, who took me apart in a witness box as a very junior paramedic over some pretty shoddy patient notes and some even more shoddy handwriting. And I think it was the handwriting that upset him more than the clinical notes. And actually, it made me focus absolutely on that kind of, I need a concise record. It shouldn't just be a list of pertinent negatives. And it should be absolutely individual to the patient we encounter. And I'm going to get on my soapbox now, Owen. And I have quite a number of soapboxes. Those who've listened to me before on this will be aware. It's very easy when we're with digital records to do that copy and paste. I've got a neuro assessment that I wrote down. Don't do it. You just end up in trouble. Records have got to be records for that patient. Copy and paste is deeply evil, and it just gets people in trouble. And I opened a clinical record recently, and the clinical impression recorded on that record: closed fractured clavicle, closed fractured humerus, urinary tract infection, and closed fractured neck of femur. That was what the impression was. And in the examination notes, it said patient mobilizes normally, no altered gait, patient steady on feet. I really don't think they were. That's clearly been copied and pasted into that record from somebody who's just written an assessment. And however much you say to me, you say, oh, I don't copy and paste. And if I do copy and paste, I kind of make sure I edit it. You don't edit it. Nobody edits it properly. Nobody reads that record. And at 3 o'clock in the morning, when you copy and paste something in and we're all tired, it's probably going to have mistakes in it. And now I read that record going, I really hope we didn't walk the patient with the neck of femur fracture out to the ambulance. But I've got really nothing to hang that on if we've assessed their mobility. So I think there is something about how we record and making sure we're actually using contemporaneous notes and all near contemporaneous notes, because actually in high acuity cases, they're nearly always near contemporaneous. And we're not just copy and pasting what we wrote last time or writing the standard stuff. And equally, I've seen some very eminent clinicians just type out what they do, use the same 5 or 6 sentences around every head injury rapid sequence induction that they undertake. It's probably also worth pointing out that I got our clinical audit team. We had a look at some other records this clinician had completed, and we then discovered the bilateral femur fracture, patient mobilizing normally, no altered gait and steady on feet. So this is clearly just people copying and pasting into records. And that really doesn't help us. It's about having that solid, concise record, what you did. And it's not pages, it is just thinking about um, what I need to write and how would I recreate that clinical encounter from my records.
Yeah, no, indeed, actually, Mark. And I'm probably going to lend it my next question to another soapbox. But one would be the next question would be how we document sort of an MDT approach, so a multidisciplinary team, be it an advanced clinical practitioner, maybe an AAP, so someone who's maybe in their earlier years of clinical practice, and indeed a paramedic, and the whole array of spectrum. Could I get you to speak to documentation which doesn't necessarily mimic what maybe just a senior clinician did, but is like you said, organic to what they did? Because like you said, it's copying and pasting from another incident to that incident is one thing, but then I guess in a way, certainly from a medical legal perspective, reading back what someone else did on scene in different guises doesn't necessarily give you a window as to what that clinician did on that scene, and just to really give those details, give the nuances, and give the an idea of what the specific roles of each clinician were. Could I get you to speak to that?
Yeah, I think one of the key things around this is about documenting your interaction in your management of the patient. They're your clinical records for your interaction. And yes, nowadays in many ambulance services, we document onto the same record. Um, I'm off to court next week with one of my colleagues, advanced paramedic practitioner, very experienced advanced paramedic practitioner, who attended an asthmatic cardiac arrest. And a relatively junior colleague wrote on the patient report form, advanced paramedic practitioner arrived and undertook thoracotomy. And clearly they didn't. What they did is they arrived and undertook bilateral thoracostomies post intubation and an assessment for tension pneumothoraces. Um, and I've now got a coroner saying, did the paramedic really do a thoracotomy? No, they really didn't do a thoracotomy. Um, it is about what you did. They're your records. If you turn up and there's a HEMS team there, don't document what the HEMS team did. That's their job and their role. Yes, you can document that I assisted. Yeah. And it's about what you found. If you're the first FRU on scene or the first responder on scene or the community responder, you recall what you did and allow those clinicians to turn up later to record what they did. So you've got a record that runs through a logical pattern. And actually, it's completely appropriate to record that I did this, and I handed the care over to these individuals who then led um, with the rest of the case. And I think that's really, really clear that actually what we should be documenting is what you did. And that helps with that record being concise, that you don't then get 5 accounts of the same thing on that record. You get a consistent account that shows that actually these are what I did, and that's what Owen did, and that's what so and so did. And so actually you've got a clear, logical following of that. And it's really important that you don't start documenting stuff that's outside your scope of practice.
Mark, could I get you to speak to something else as we pivot slightly and look at handovers really and how we document and indeed communicate during handovers? Because transitions of care can be tricky, certainly from a clinical perspective, but also from a medical legal perspective. Could I get you to speak to just the role of effective communication and indeed documentation from pre-hospital teams to hospital staff, and how it can impact patient outcome, but also it can impact legal risk as well. Could I get you to speak to that?
Absolutely. Handover, I think, is the greatest period of risk within any episode of care. I think where that patient's being transferred between agencies, between care providers, provides an absolute risk. And I think we don't value handover enough. And I think as an individual who receives a lot of handovers and also transmits a lot of handovers, I don't think we value that enough. And I think there is something around how we structure our handovers, however experienced we are, making sure you think about um, what you want to transmit in that handover, having that structure tool. I really like the SBAR tool. I think it provides a really good summary tool. I think ATMIST or in trauma is equally a concise tool. So um, all of that takes you through a logical pattern, and that you actually prep for that handover. So you think, actually, somebody's arriving, I'm going to hand this patient over. I take that time out, that 10-second time out to structure my thought process. And I'm also of the view that we also have to be aware what the human attention span is. And that attention span under periods of stress and need to intervene is really quite short. And if you can't hand that patient over in 40 seconds, I think you're probably saying too much. And I really like that kind of take your time out, plan that handover. Um, many years ago, me and Owen trained together. It was a long time ago, but I learnt doing that. Actually, take that time out, write your handover down on a scrap of paper, write it on your knee pad, write it somewhere. Make sure you dispose of it confidentially, obviously. But then you've got that prompt, so you scribble it down, and even that's what I do right now today. If I've got a complex handover that's got some timings and cardiac arrest patient, knowing that they're going to want to know no flow times, low flow times, things like that, that's really, really key. But the other bit around this is also how you receive that handover. And that's absolutely important. And where we have to practice what we preach, and as individuals who turn up and take multiple handovers from clinicians in our clinical practice, we also have to be in a position to receive that handover. And there is a lots of stuff you can do to make yourself better able to receive that handover. Say to somebody, let me put my bags down so I can concentrate on what you're saying. Open and steer the handover. Is the patient got an immediate need I need to do right now? Is there something that's really worrying you I can get on with right now? Or are we in a position to hand over formally? And then listen. Yeah. Don't interrupt. Allow the handover to continue, and then get to the point if you can ask questions and clarifications. But you can also steer, and you can also steer that handover into how that handover is received when you're handing over in a hospital setting. We're pre-hospital providers. I'm an absolute view of when I walk in, I identify who's in charge, and you say, patient's got no immediate needs. If you're happy, we'll transfer the patient onto the bed. You can transfer monitoring, and then we'll hand over once you're happy. So you can steer it like that. You can equally go in and say, we've got some immediate clinical needs. I'm going to tell you about that before we transfer the patient so you can crack on straight away. I think it's really helpful to ask that question, is everyone here who needs to hear the handover? Because actually, often they're not. And often, actually, you've arrived a little bit earlier. The key clinical decision maker hasn't yet arrived. They're busy doing something else. And actually, sometimes it's okay to say that handover will wait a few seconds. And particularly when you're taking patients into clinical settings more and more commonly, which are not used to receiving handovers, how you do that. And equally, it's really important to use a structured tool. Work with clinical providers to make sure that structured tool is providing the information they need. Allow an opportunity at the end of the handover to ask questions and to summarize what you think. And the Zen gods of handover, and they are out there, will absolutely do that. They'll get to the end of it. They'll summarize what they've just said. So this is patient X. They've any questions? I'm also of a view that at that point, you've handed the care over. And unless there is a need for you to clinically be involved in that patient, step away from the patient, allow the team to assume primacy of care. Because it also then helps that it's not a continuum of handover. The handover is completed, and then you can step away. And it is worth sometimes then identifying if somebody's scribing or bits like that, you can go and clarify drug doses, bits like that they may not have caught over. But I think it is that kind of process of have a plan, rehearse the plan, stick to the plan, and also make sure that we're as good a listener to handover as we are as transmission of handover, because we can all make that mistake.
Yeah, listen, there's the points you make are absolutely fundamental, Mark, and I couldn't agree more. And I think you're right, both as recipients and indeed as transmitters of handovers, it's prudent to recognize the finite nature of the short-term memory. And like you said, holding 7 pieces of information plus or minus two, but if you can easily overwhelm the recipient of a handover of information, and less is more fundamentally, as you said, and then that summary and making sure that everyone is around that needs to be around to listen to the handover and that can come back for more. And I think the more complex the situation, albeit maybe a multi-patient road traffic collision or indeed any other multi-patient scenario, brevity even there is your friend, even more brevity, because there's almost this multimodal sensory overload, and the sense of triage, information triage, becomes almost overwhelming if you do an extended dialogue, which, like I said, won't add to effective clinical decision making. So it almost the more complex, which is counterintuitive, but the brevity should increase, actually, as you were saying. Mark, could I get you to speak to on the back end of that, because there's a unique perspective that you see a lot, and actually maybe you're going to quote around this next week, is the fact that when there is a medical legal case, and the care afforded to the patient from the hospital is cross-examined, and indeed pre-hospital is examined, there is sometimes not necessarily transferal or transposal of blame to the pre-hospital services, but I've certainly witnessed, and indeed you have, if unless there's robust documentation on both sides of the fence, both pre-hospital and in hospital, it is extremely hard to defend pre-hospital cases. And indeed, even on handover, if there's questionable care or indeed information on handover. Could I get you to speak to the importance of clear, concise, and indeed robust documentation of of that handover, that the handovers occurred and what occurred at handover, especially in critical care or indeed complex cases, so that there is almost this synchronous rather than asynchronous kind of reflection of care?
You're absolutely right, Owen. I would hate to think the number of cases I've been involved in with the medical legal hat on where information fails to transfer. And when I say fails to transfer, it is either not transmitted or it's not received, between a pre-hospital care team and in a hospital care team. Whether that's a clinical impression hasn't been transmitted, whether somebody's not listened to the information. And I think it's really key that we get better at this. I'm also very much of the view that we have this nasty habit of blaming each other when something goes wrong. And I think rather than looking inwardly about what we could have done differently and whether we were able to do something differently, we look outwards to blame somebody else. Oh, only if the pre-hospital care team had told us that, or only if the hospital had listened to what we'd said, the outcome would have been different. Rarely would it have been different, is my experience in this. Rarely does it. Yeah. But I do think we have to have this structured kind of handover. I'm a strong believer in that kind of staggered handover, particularly when there's complex information. I was involved in a case recently, it's the kind of nightmare pre-hospital case for most paramedics of an entrapped breech baby who we managed to successfully deliver and we resuscitated. And there was wrapped up in this quite a bit of safeguarding information, all absolutely vital and really key. It was handed over. Um, but what we did is we did the handover. We handed over the now alive baby, and we did that. And I said very clearly at the end of that handover, there is some key safeguarding information that we need to hand over to you, but we'll come back and do that. And what we did within our clinical notes is said, we did a really detailed note of the safeguarding as you would expect. But we made very clear that actually we'd handed this over to a named individual. And we went back in 10 minutes later, once they'd got the baby even more settled, and went, let's go through this safeguarding. And we did it in a much more controlled, calmed way. But that you then record that you've handed that over and you recapture who you handed that over into. I think it's also really key that often, and I spend a lot of time talking with hospital colleagues, is what we consider insignificant may play a really vital part in that hospital's ongoing management. If you're sat there and you go, I've got a diagnostic quandary, it could be this, it could be that, I'm not quite worked it out. Say that and tell that in your handover. My impression is this or this, I'm not 100% sure. because then it starts people's thinking that actually you've just spent the last hour with that patient. So tell people and share that and actually record, handed over clinical equipoise between two impressions, which is a very posh way of saying I wasn't quite sure, so I had two ideas. But saying that, of saying this is what I've handed over, I've spent too long now stood in court defending ambulance clinicians where somebody go, oh, we weren't told that at handover. That's where the clinical record is important. It's where you capture the information on your, and you actually, I now continually to say the clinical handover is not just the verbal transmission of information at the end of the bed in resus. It is also the records that you pass on to that hospital. And both of those form your handover of care. So if it's missed in one, it should be there in the other. I spent some time recently talking with hospital colleagues about how we create that environment for that handover and how do we do that with technology. And I went into hospital recently, who will remain nameless, who've decided to take their resus handovers around a computer at the back of resus. And I think it would be fair to say, with a critical care patient, something be less appropriate, away from the patient, without the ability of the clinicians receiving that handover to be eyeballing the patient at the same time. And actually, it's about how we create that environment to receive that handover. And we do that all the time in pre-hospital care. You can be a very junior ambulance clinician taking a handover a community responder. You've got to create an environment where that handover can be received, which is about making that time, as we talked about, all of those little human factor things, putting that bag down, taking that, actually getting that pad of paper out, thinking, do I need to make a note? And sometimes saying to somebody, that's absolutely clear and that's really important. But what I'm going to do is just pause you there whilst we crack on and just do the two or three things that I can see as immediate clinical needs. And then I'm going to come back to you and get the rest of that really great information. And sometimes you've got to stagger that handover to allow clinical intervention and intervention, but also use that documentation record to supplement your verbal handover. Because actually that's what will provide the defence when somebody says, oh, we were never told, we thought it might be sepsis. And you go, well, it's on the clinical record.
No, absolutely. Absolutely, Mark. In a way, could I just get you to speak to a case study? I'm sure you have many actually, Mark, where poor documentation and indeed communication led to legal and or patient care issue, and indeed how it was resolved. I mean, you've just spoken that you are maybe continually bumping up against this where there is a dearth or an absence of documentation, and it's trying to fill in the gaps retrospectively with crew interviews to try and get more information and document information on an interview. But could I get you to speak to some of the tools in your toolbox, and indeed maybe just from a case study, just to illustrate how difficult and how much it can really leave the individual and the service open?
I'm going to pick two case studies, both about too little and too much documentation. And I was recently involved in a case where it was an assessment of a patient who had an atypical presentation of a stroke. Yeah, this wasn't the classic fast positive stroke. It was clearly somebody who had a sudden onset of altered neurology, but atypical altered neurology. And this was a crew who ultimately got cross-examined in court by a very experienced barrister, and I'm sure who, I suspect, certainly cross-examined me in the past. And she asked the question of the crew who'd written cranial nerve NAD. And the first question this barrister said is, can you talk me through your examination of the first cranial nerve? And there was this kind of tumbleweed moment across court number one at the Royal Courts of Justice, as this ambulance clinician stood there in this witness box going, which one's the first cranial nerve? Well, had they assessed that cranial nerve? Had they just done a cursory neuro exam. And if you've just done a cursory neuro exam, right, I assess this, this, and this. Don't write, I assess the cranial nerves, because some barrister, probably assisted by some overpaid expert witness, is going to ask you, and how did you assess the olfactory nerve? Yeah. And how did you assess the sensory or motor component of one of the other nerves? So actually, sometimes you write too much. And actually, if you've arrived and actually what you've done is a fast test, and you've got the patient smile and show you the teeth, say that's what you've done. The patient was able to smile equally. They were able to show me your teeth equally, and there was no office facial droop, rather than sometimes writing this stuff where we just go, is that really what occurred? Most of us learned our cranial nerves. Most of us were able to do an OSCE on them. Even some of us may still be able to do it. But actually, how often are we truly doing that in routine ambulance practice? I see a lot of neuro exams done in my practice. I very rarely see a complete cranial nerve examination done. And that's the example of perhaps where writing too much or writing not the right information can cause you some trouble. I was recently involved in a case around immobilisation. And this was a gentleman who had had a significant amount to drink and had fallen climbing the stairs in a pub. He'd gone down to the basement toilets and didn't make it upstairs from the basement toilets without taking a trip back down the stairs. And I think everyone agreed that this patient was really challenging to manage. He'd attempted to get himself back up the stairs. He'd attempted, we think, and there was a debate around whether he should have been immobilised or not. And there was a very strong view that his neurological injury would not have been as bad if he'd been immobilised. And I'm not going to get into the causation argument about collars and bits like that, but there were two real bits of this clinical record that were missing. The first of which was, what was the patient's motor function and sensory function on arrival before any intervention took place? Was this patient moving their arms and legs? Because if they weren't, all of that causation stuff goes away at that point. So that really early, what did you find when you were arriving? And that's really, really key. Is actually, what did you find when you walked in? Before you undertook anything, before you did anything, what was the things that you saw and what happened? And then the other bit was, if you wanted to immobilise this individual, record you wanted to immobilise him, but record why you weren't able to. Record that you wanted him to minimise movement, but you weren't able to because this and this. Record that you'd attempted to counsel the patient on the consequences of continuing to move, and record what else you considered. Record that you actually may have considered a critical care resource, but there was none available, or you knew it was going to be a long time, and in this quite remote environment, this wasn't immediately practicable. So actually record all of that. So I think there's two bits of, and I look at this case and think, if only that documentation had been a bit different, perhaps I wouldn't have ended up spending a day in a witness box trying to defend this case. It's saying that absolutely, this is what I found when I got there, and this is what I wanted to do, but I wasn't able to do it. And one of the things that often ends up and causes us challenge is that we use convenience of documentation. It's convenient that the patient's declined, so we'll just write declined. Has the patient really declined? Or actually, has we talked the patient out of going to hospital? Because there's a big difference. Did the patient decline immobilisation, or did we not offer it? And actually, that's really key, is that whole difference of those subtleties. And record, if you wanted to do something, I wanted to do it, but I was unable to do it because X, Y, and Z. And actually, these don't have to be long, convoluted. I'm a big fan of bullet points within clinical notes of this is what we advised, and this is the risks and benefits. And again, you look back and you look at cases that I've dealt with, all of the time it's about that risk explanation to the patient and recording that you've explained the principal risks and benefits to that patient to allow them to make that informed decision. And that's so much where particularly paramedics end up in trouble is that it's not that the patient's declined hospital, but it's the fact we've not really informed the patient of the risks of the decision they're taking, and we're not doing that in a meaningful way. And certainly the newish case law of Montgomery in terms of consent is really helpful about the risks that that patient would have held important to them, and being able to capture that. And that's a real bastardization, really helpful case law. And actually, if you are undertaking any bit of pre-hospital care, have a look at the ruling in Montgomery, have a look at some of the easy read stuff. There's some great stuff out there from some of the big medical negligence firms that help Montgomery, because actually it's really helpful and it does focus your clinical notes. And I think the kind of other bit for me is that at the subsequent board of inquiry, be that a inquest, be that a public inquiry, be that a civil claim, be that a criminal claim, what would your notes read like? Yeah, have that in the back of your head. Have it in your head that actually, if this all went wrong, how would my notes read? Have they passed the test of actually, somebody would be able to defend my care based on these notes? And I think that's the question that I ask myself. I think about the most grumpy lawyer I know, and I know quite a few grumpy lawyers, and the most grumpy expert witness I know in pre-hospital care, and I know an awful lot of those. And most of the time, the most grumpy one I know is myself. Is that what would I say if I read those notes cold on my desk on a Sunday morning when I'm doing a bit of private report writing? What would I think? And would I be able to defend the care on those? Would I be able to stand up in a witness box and say, this is why I did something and my rationale is this? Or this is what I did and my rationale is this?
And I think just the answers there, Mark, are completely logical. And when you hold them up in a clear light of day, it actually completely makes sense to be honest in your documentation. Like you said, explain the consequences and explain the reasons. Again, it's about rationality and reason. This is my proposed plan. This is maybe why I couldn't execute such plan, and then the confluence, or indeed the implications of what did occur. And you're right, bullet points, brevity is your friend in a way that you can allow the reader to access the information. Brevity, but still detail enough so that there is a good image or indeed picture of the complete package of care. I guess my question on the back of that is, how can pre-hospital providers really defend within their documentation sound clinical decision making? So sound clinical judgment and decision making when their documentation is scrutinized. Is it sufficient, like you said, not only just to put logical information down in sequential fashion, so chronological fashion, but also is it reasonable to say, we had some shared decision making from the team, and this was the summation of the shared decision making for the patient? Would that be reasonable?
Oh, absolutely. I think where you share a decision, and we spend a lot of time talking about complex decisions and no complex decision in isolation or no decision in isolation, record that and say, actually, I sought advice, be that top cover advice, be that peer advice, and we came up with a plan. Discuss if the patient lacks capacity, who you may have talked to gain what the patient's view might be. I actually, it's right that you've chatted with the patient's family, you've discussed what they think the patient's view about this would be. Bring them on that journey with you and record that in your record keeping. And these don't have to be long records. They are not 1,000-word academic essays that you're going to get marked on your referencing style in them. But these are concise notes, and actually some of the best notes I see done are often some of the shortest notes, where people are just really punchy about what they say. I did this, I wanted to do this, I wasn't able to do this. This is what I told the patient. Um, and this is the rationale of why I discussed that with the patient. And every record you undertake, and I come back to that kind of test of being able to recreate the consultation and the event from it, is really important. But the other bit of which is, have a little back of your mind, think, is this something that's going to come back and haunt me? We all know those pit of your stomach calls where you think, oh, I'm going to be filling out paperwork for this for the next 6 months, and making sure you have a double look at those. and I say this to our senior clinical team fairly regularly, when you finish that case, just read through the note in its entirety and read through the clinical record in its entirety and say, actually, does this make logical sense to me? Could I absolutely stand by this at a subsequent inquiry? Um, and I think that's really helpful, and have that critical eye and that self-criticality. And I'm a strong believer when I work with other people, I'll hand them my clinical notes and say, read it. Have I forgotten anything? Have I missed anything? And get that double check. And that doesn't need to be done by somebody as a peer, senior. Actually, I get anyone I'm working with to have a quick look at the notes and check that they reflect absolutely what I think should go on. And there is a difference, isn't there? There is a difference between the patient that you might leave at home and the risks that that presents versus a patient who has relatively limited clinical interventions gets conveyed. Um, I'm also a strong believer if something causes you a delay on scene, record why it caused you delay. It took us a bit longer to move the patient outside because we had to move the sofa that was on their staircase. Write that down. Write down that actually you had a delay um, um, unloading the ambulance because the trolley bed decided not to work. Write that down. So record it. So when somebody's looking at saying, why was that scene time 40 minutes, not 30 minutes? That actually there's a clearly logical pattern of that. And because most of us will not remember that call particularly well. Um, when it comes to you 5, 6, 8, 10 years down the line. And it is worth remembering that clinical negligence in respect of children, I've got a case now that I'm looking at that's close to 15 years old. How on earth is the paramedic going to remember that? They're not. They're completely reliant on their documentation. Um, and again, however well you think you might remember it, it's your documentation that is the bit that will cast your mind back and give you that reflections and insight. So that really good notes at the time. And I go back to full, clear and accurate records for everyone you treat. And they are not an add-on to the patient care. They are part of the patient care.
Listen, that's fantastic, Mark. Absolutely fantastic, and almost a really good place to finish. With just one more question, really, would be because you've really, I think, in a way, really answered how we can prevent legal issues arising from poor documentation. Everything you've just said around, just getting someone else to read back, reading it back yourself, getting someone else to read it back, asking, have I missed anything? Looking at the retrospective scope of documenting it as well. What I realized is not leaving, if you're tired, not leaving documentation to aggregate or collect, putting it down on paper or indeed on the iPad after the incident in as much detail as possible, because you're right, the short-term memory, even a day or two after, forget years, it starts to lack detail. Your mind starts to be full of other things, and you start to lose this semblance of detail to what could be quite important information, because you said it before, barristers can pick up on the smallest thing and really start to zoom in on these things. And actually, it's prudent to have consistency amongst your documentation, consistency to detail, consistency to that sequential chronological documentation, which you're right, someone else can almost be there imagistically. They can read that documentation a week, 2 weeks, a month down the line, and almost picture what went on in sequential fashion in because of the robust documentation. I guess just as we finish off, Mark, because you've given us some fantastic points just to go away and reflect on. How do we train and improve documentation? How do we, indeed, two facets to this question. One would be, how do we improve and train for better documentation? And how do we train and improve for better communication within pre-hospital teams to reduce the risk of legal challenge?
So I think there's a couple of bits to that. And the first thing, and I say this fairly frequently, good documentation does not make up for bad clinical care. You cannot justify a bad clinical care on the basis of a good piece of documentation, despite what some people think. And very rarely, and I fairly frequently will pick up what looks like quite a decent record, and you read the record and you just go, this is just hiding what was a really poor piece of patient assessment, a piece of poor clinical advice. So I think the first thing is that good documentation does not get you out of bad care. And actually, it's about the kind of professional approach throughout it. I'm a strong believer around actually when we're doing sims, when we're doing moulage, whatever we choose to call it, deliberate practice stuff, actually we should be considering documentation as part of that. And one of the things you'll remember doing, Owen, a number of years ago was we did some scenarios around management of acute behavioural disturbance. And one of the things I made you and others do is go and write your notes. I just literally come out of a very problematic inquest around an acute behavioural disturbance patient. And we did these scenarios. We were working with the police, and I said to people, go and write your notes. You've just managed this patient in a scenario environment. Off you go and write your notes. Go and sit down, write your notes. And actually making people do that. And then we came back and we looked at the note. And did that note reflect what we'd captured in that scenario? Did that note reflect what you'd actually done? Did it explain why you'd chosen sedation agent A over sedation agent B? And I think we should do that within our scenario training. And I think one of my things to all of us who are involved in the education of paramedics is this is not an add-on. You can't expect people just to absorb this. This isn't something that can only be learnt in practice. We need to be teaching people clinical documentation. We need to develop models of clinical documentation suitable for pre-hospital environment. We also need to be training people using the technology tools that are in use available now. It's no good getting somebody to write a PRF if actually what they're doing is typing on an iPad. So that's what we should be doing. And it should form part, at least to some extent, of our scenario training. I also am of the view that we should all have an understanding of giving evidence. We should all also practice statement writing. There is nothing like being cross-examined. And I think we should absolutely do that. We should do mock inquest stuff with paramedics. We should do mock inquest stuff with FEM trainees to make sure they're really equipped to stand in a court and defend their care. And it's something I'm really passionate about, is actually that you don't want to learn this on a real case. Actually, there is something about how do we do this. And some of this we should be able to do now with technology. We should be able to do this virtually. And actually, it doesn't necessarily be your care that has to be cross-examined, but it could well be you watching somebody else's. And so you learn that. And there are many hints and tips, one of which is never write two statements. And because actually any barrister who ends up with two statements in front of them will just pick holes in the differences between them. If you need to add something to a statement, you don't rewrite a second statement, you do an addendum to it. All of that stuff is really helpful to learn, but nobody actually tells you that until you get to a point where you've gone, oh, why have I got two statements that say slightly different things? I'm a strong believer, and I say this constantly, if you're being asked to do a statement for the police, you write that statement for the police, but you also include enough detail in it that it will also satisfy a coroner if it got released to a coroner. So you then don't have to do two statements. All of that, if you're being asked for a statement from the IOPC, you write it that it would also be satisfactory if it got that. And now, if you then come back and actually, I need to put some more detail into that about that or that, you don't do that as a new statement. You just do that as a signed addendum to the statement. So I'm now adding this, this, and this. And again, that's all stuff we have to train and teach people, because actually, unless you live that, you don't know that. And I think there is something about how we bring lawyers into paramedic training far earlier. And actually, you have somebody who can look at your records and go, that's not the way I'd be phrasing that. That's not how I would want that written. And actually being really open about actually where you have taken a dynamic risk assessment, or you've taken a dynamic assessment, right, I've taken a dynamic risk assessment based on X, Y, and Z. And that's the bit that you learn that says, actually, I've had to take a dynamic decision. This is the rationale for it. I've balanced this and this. And that's how you get really good notes. But I think we've got to take record keeping to a whole new level. I think we've got to embrace the technology there. I think we've got to think about how dictation works for those of us who are not natural typers, and perhaps not natural writers. There are many of us who probably are not, or certainly started our ambulance career, not natural writers, as I'm sat here this evening going to write, just finishing a 30,000 word report. But actually, how do we get technology? How do we do that with voice transcription and bits like that? And where does video and other bits sit into this? Where does imaging sit into this? And how do we do that? And how do we look forward to what is the next bit of this? And actually, is there a role for AI? Does AI have a role in voice transcription of an clinical history taking? Could you get AI to summarize your clinical history? I'm not sure that technology is there quite yet, but I'm not sure it's that far off. But I think it's all about that. But the right here and now is that kind of clear, full, accurate record. Thinking to yourself, if I looked at this 6 years down the line, would I be able to recreate that consultation? And would this stand up to being cross-examined by the most grumpy barrister you can imagine?
No, indeed, Mark, indeed. And just to finish off, something you said earlier, which is extremely powerful and should actually, form part of not only assessments but of training, is giving handovers in simulation, giving handovers in training, and learning to critique handover as part of the debrief. Because, like you said, handovers, there's a full spectrum of quality and maybe not so quality handovers, but getting feedback on the spoken word, on the communication you give, on the brevity, on the clarity, on the summary, to your point, summarizing a handover, and then maybe getting a read receipt, allowing clinicians to come back for more. But training for handover, because like you said, there's one thing, there was a real dearth and an absence of training within medical legal documentation. There's a real dearth and an absence of formative handover training, which I would love to see being embedded.
Absolutely, and I couldn't agree more. I think we need both to embrace handover training. It needs to be part of scenarios, but not only the transmission of the handover, the receipt of the handover. We also need to learn how to receive handovers. We can't be critical of others not receiving handover well if we're not doing it ourselves well. I also think there is a lot to be said for joined up training around handovers, about how you receive a handover. We've done some work with one of our centres in London, and we took a department who were pretty awful at receiving handovers down and stood them in front of a colleague of ours who we know well, who is an absolute zen of receiving handovers in major trauma, to learn that skill. And we stood them in the back of the resus room at a major trauma centre to watch a kind of absolute expert receive a handover with that prompting questioning. And I think there is that and I don't think we do enough with our emergency medicine colleagues about actually how do you facilitate a handover. And we need to train for that. We need to train how to deliver a handover. We need to train how to receive a handover, and we need to work with others so they can do the same and join it up. I also think that there is a lot of hints and tips about how you can facilitate that handover really well, and how you can actually prepare for that handover to be received. And it's little things, identifying the team leader, talking about what your handover plan is, being open about immediate needs, staggering that handover, there's complex information, making sure you take the time to go and speak to whoever's scribing at the end of the handover, that they've got the details down. All of that stuff is really powerful. And we should also be practicing that about actually how do we prepare that handover, and how do we make sure that we facilitate an environment where that handover can be received. And again, a load of that is that stuff about at least that most of us can only do one thing at once well. So allow them to get the monitoring attached to the patient, allow the patient's defib to be transferred over, whatever it happens to be, allow that to happen if there isn't immediate clinical urgency to hand over. And then you've got people's concentration. It's the hands-off handover. But if you're doing that hands-off handover, it's also remembering what the human kind of attention span is, and it's shorter than you think, which means you've got to have prepped your handover before.
Mark, listen, thank you. Thank you for the last hour. It's an absolute privilege to get your reflections and indeed thoughts on both of those. So thank you. And we'll be seeing you again shortly for part two. So thank you, Mark.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.